Hello, everyone, and welcome to this episode of Truth Shots with Kapil Narratives and Neurons. It is with extreme pleasure that I welcome Dr. Sneh Bhargava, um, an ex director of AIIMS, the first women director of AIIMS, a Padma Shri awardee, a professor emeritus of AIIMS. There is so much that we can say as introduction for her, but then she is someone that does not need an introduction at all. She is one of the most distinguished medical professionals, as well as I mentioned, the former director of AIIMS Delhi. With a career spanning decades at the forefront of radiology and hospital leadership, Dr. Bhargava brings an unmatched perspective on how Indian healthcare has evolved and where it needs to go next. Her inspiring journey will be chronicled in a book called as The Women Who Ran AIIMS. It's on the shelves now. Please go ahead and read. I read through some of it last night and it was just wonderful. It captures the stories of pioneering women leaders who have shaped one of India's premier medical institutions. We will discuss her experiences of leadership, breaking barriers, and what it means to be a woman in Indian medicine. We dig deep into the often overlooked but critical role radiology plays in diagnosis and treatment, the realities of healthcare management in India's top institutions, and the leadership challenges that comes with steering large-scale medical organizations. Her story is a testament to perseverance and excellence, inspiring young medical professionals while challenging the system to be a better, more patient-centered and transparent. Ma'am, welcome and thank you so much for agreeing to be on this program.
My pleasure.
Ma'am, I want to right away start off with your experience as the first women AIIMS director. I read in your book and I am aware that it was quite challenging at that times to break through the ceiling of AIIMS, which has always had male directors. So how was that experience for you?
I had served AIIMS for 24 years before I became director. And when you are director, your main job is to maintain the status that AIIMS had attained and also to make it grow. So, and my being a woman did not come in my way because all my colleagues who had interacted with me for 24 years knew that if I want to do a job, I would do it and do it well. So I faced no gender bias.
Perfect.
Inside. Outside, of course, after I'd taken charge, a couple of days later, my secretary said, "Ma'am, there is a call from the External Affairs Ministry. The secretary wants to talk to you." So I said, "Put him through." And he put me through. And I said, "Hello, Mr. So-and-so, how can I help you?" So he said, "Oh shit, they've connected me to the house." I said, "No, they have connected you to the director. And I am the director, Sneh Bhargava. You can tell me what your problem is and I'll do whatever is required." So his immediate answer was, "I'm so sorry, ma'am. My male chauvinism did not prepare me to hear a woman at the other end as director. My apologies." So that is how outside looked at me. Then a few days later, the secretary said, "The chief minister of UP wants to speak to you." So I said, "Put him through." So I said, "Hello, मैं आपके लिए क्या कर सकती हूँ?" "महिला है डायरेक्टर एम्स की." मैंने कहा, "हाँ, महिला है डायरेक्टर एम्स की." So this is how the outside looked at you, whereas my colleagues, I had no problem.
Okay. Did you look at, so when such incidences happen, whether it is the external affairs minister or chief minister or anybody else, did you look at that as, a moment of pride, saying people are now getting an acceptance that women can go everywhere?
Yes.
Or was it, a feeling of, they still don't understand? So which of the two was more prominent for you?
A feeling of pride. You have to accept us. We are there. We are 50% of the population, so you might as well accept us.
Absolutely, absolutely. And from there, I mean, if you look now, there is a huge change that has happened in terms of women in the workforce, in terms of women's acceptance in all sorts of roles, almost everywhere around the world now.
Yes. Well, what has it happened? How has it happened in India? It is still a patriarchal society, right? I was not only the first woman director, but so far the only woman director
Sure.
for AIIMS history of almost getting on to a century,
Sure.
which will be in a few years. So the problem of patriarchal society persists.
Sure.
And I think only the mothers have to teach their sons that the girl is as important as the boy. But mothers all over the country have not yet learnt that lesson. It will take some time, but girls are doing very well. As far as admissions to medical schools are concerned, they form 51%
Right.
of the admissions. So that's a big change from what was maybe 1% of the total admissions in a medical college. And the only women's medical college in the country was at Lady Hardinge Medical College, and there they took only 50 girls. Right till for a few years now that they have started, after changing the rules, take now 100 girls still at the undergraduate level, but at the postgraduate level, it has become a co-education institution.
At the master's level.
Yeah.
Right. So, in terms of challenges as the medical director in AIIMS, what would be the top one or top two challenges that you would have faced during the years?
Well, the day I took over from my predecessor, I asked him, what is the most challenging thing and problem that I have to address that you have faced? So I will take the cue from you and start accordingly.
Sure.
And he said to me, housing, housing, and housing. What does that mean? Rajkumari Amrit Kaur, who was the creator of AIIMS, she insisted that houses be built on the campus so that the doctors could live not having to worry to travel to work every day.
Sure.
And should be available at the touch of a button. They should be available. So housing was very important, and she created that. But over the period of time, the progress of AIIMS in terms of catering to healthcare, it had increased such a lot that housing was now fell short. So my main job, it seemed to me, was to tackle the problem of housing, which I did by various means.
And ma'am, you are a Padma Shri awardee. So if you can talk about how that experience was.
I think there you can say that I, of course, did not go to anyone to ask to get a Padma Shri. And I was actually out of the country when they made the selection.
Okay.
And my husband called me and he said some people had come from Rashtrapati Bhavan to find out whether you would accept the Padma Shri or not. So he said, I have told them, yes, she will accept it, though she's out of the country. So that's how it happened.
Fantastic. And ma'am, many of our readers, many of our viewers would want to know, why did your book come out so late?
I had never thought that I was going to write a book. Maybe during my active life at AIIMS, I didn't have the time even, and I never thought in those terms. So if I had thought of that earlier, I should have kept records of various incidences that occurred with their timeline, etc., etc., so that you could document it.
Right.
Since I was so busy, or maybe so involved in the department as well as in the hospital and with the faculty, that I did not think in those terms. So I had no records. The only record I had was a, a book or a diary which said mistaken diagnosis. If I had made a diagnosis which was not turned out to be correct and it was mistaken, then I recorded that so that I would never make that mistake again.
Sure.
And I showed that to my students also, that you will make mistakes, but you don't repeat a mistake. So that is what you should learn. Now, that's the only book I had. So as I said, I never thought of it. But after I retired from AIIMS, I didn't retire from life. I picked up jobs in 2 hospitals in Delhi. And there also I kept no records. So I was hesitant when friends asked me, why don't you write your memoirs or your autobiography? I said, I can't because I have no records. I can't do it. And that's how I kept putting that off till we reached COVID. And both hospitals, I was by that time 30 years at Sitaram Bhartiya and 30 years at Dharamshila. And when COVID struck, and I was 90, so they said to me, both hospitals, we don't want you in the hospital. You stay at home. So I had no choice but to stay at home. And at that time, I thought, well, I've got nothing else to do. Let me put pen to paper and see if I can do any writing. So once I started writing, then things came back to me mentally, and I went on writing till the end, and then I started to ask, how do I publish this?
Sure.
And then learned from friends that this is how you go about it. And that's how I got in touch with Juggernaut.
So the first time in life you faced discrimination, you turned from a healthcare professional to an author.
Yes.
Wonderful. Some of the stuff that I have read, I'm sure the audiences would not only enjoy reading it, but it will give them an extreme amount of insight into your life as a medical professional, but more importantly, medical professional in general, and inspire many people to take on the profession. Now, you talked about you getting out of healthcare when COVID hit, and of course that had to do with the fact that you would be in a very susceptible population. What did you see as evolution of healthcare in during the pandemic and in currently the post-pandemic world?
I think the most striking thing was that healthcare budget had been 0.9% of GDP till that,
Right.
not that till that period, but for a long period, right? And it came out so correctly that we had totally neglected, we means government, had totally neglected the healthcare sector. And it hit hard that hospitals that were run by government did not have oxygen.
Right.
So the government's part in giving funds to healthcare to train people and equip hospitals with basic things, leave alone advanced technology. The hospitals did not have basic things like oxygen. So that struck the government, and then the government started taking care. Yet they expected the doctors to deliver day and night and in every hospital. And the doctors delivered the best that they could. I don't think the government could complain that the profession did not stand up at the time of need. The profession stood up, but it hit the government hard. And they started then to give more importance. And right now, the present government is giving more importance, but it will take a long time for us because the basic requirement is what we call primary health care. If you have a backache, you don't go to an orthopedic surgeon or to a neurosurgeon. You must go to a generalist. He is cheaper and will use technology limitedly. And if he can't do anything, he can refer you to the neurosurgeon or cardiac surgeon. But you should not go directly. Today, what is happening is in urban India, you go directly to a specialist. He is considered higher higher in the profession. And because we have systematically killed the general practitioner. The family doctor no longer exists.
Right.
The family doctor looked after you from cradle to birth to
And would
death.
be aware of most
And
of your challenges.
And the family would consult the family doctor even in marriages,
Right.
leave alone health care. But today that is not there. As I said, if someone has a backache, they go directly. Now, that not only puts up the cost of health care, it also takes away the time a specialist should be giving to any patient. Because if a generalist has seen and the generalist refers you to the specialist, you get more out of healthcare than if you go directly. Or you read Google and then you go to the doctor and says, Google says this.
Right.
I know, and we have to spend half an hour trying to explain that everything on Google is not right.
So there are three problems that I keep hearing from doctors these days. Number one is since pandemic, and during pandemic, and of course after that, there is a realization and there is an ongoing crisis of mental wellness amongst doctors. That's the first challenge that I keep hearing. The second challenge that I keep hearing is the challenge of WhatsApp. Doctors doctors, and I actually hear this very significantly from teachers as well. They are very fed up and they are very, their working hours have totally gone for a toss because of WhatsApp. Patients and students and parents in that sense expect you to be available 24/7, expect you to be superhuman and be there. And the third is, of course, what you just mentioned around the use of technology, specifically, use of things like WhatsApp and Google for doing all your research. And then that thought of, always doubting and questioning what an expert's point of view or an expert's opinion is. And that also transcending boundaries.
Yeah.
So something that they would read on Google about a certain disease, about a certain problem, about something that happened, in Africa as a underdeveloped country, or in the United States as a overdeveloped country, they would look at the same paradigms and come up with answers from an Indian perspective. In your experience, how were these three in your profession or your experience as a professional?
I explained to you that the working hours of the doctor, let's start from the bottom level. A resident. A resident sits in the OPD at 8 o'clock in the morning and she is working non-stop till, say, 12 noon, right? Then he gets out of his room because he also is tired, and he gets out of his room, peeps into the corridor and sees the queue is still long.
Still long, yep.
So what does he do? He knows that he cannot finish this queue by examining everyone properly. He probably will spend 1 minute just writing, get an X-ray done, get a lab test done, and that is how he can finish the remaining queue. 1 minute.
Right.
Right? He only decides whether you're fit to be admitted or not admitted.
Right.
He has no more time than that. And then, if he doesn't leave at 1 o'clock, he goes to the mess or to the hostel, the food may not be available.
Right.
Right? And if food is not available, he is tense, he's stressed, because he has to go back at 2 o'clock to start the specialist clinic. So what do you expect? After all, he's human. He's going to shout at the top of his voice if he doesn't get ice cream in the refrigerator.
Right.
So and he then is working not only the normal 8 hours as the world in the West would do, they won't be work a minute more than 8 hours, or he has to realize that his job in India is far more different than what it is in the West, which he wants to ape. Right? Now, this is at the level of the residents, at a junior level. Let me tell you my own experience at the level of the consultant or the professor. I was recently admitted to the AIIMS hospital for a health check, right? And the gastroenterologist who was to come and see me, I was admitted under neurology, was having few tingling numbness in the feet. So the neurologist said, while you're admitted, why don't we get the gastroenterologist to attend to your tummy problems? So I said, well, all right, I'll go through that. And the gastroenterologist was to come in the evening, or was to come and see me, right? And he didn't come till the evening, so I wondered why he didn't come. And next morning, when the neurologist under whom I was admitted asked me, did the gastroenterologist come? I said, no, he didn't come. Maybe he'll come this morning. So she took out her mobile and called the gastroenterologist. And he said, I was in the OPD till 8:30 p.m. Right? So this is at the consultant level.
Right.
He is in the OPD. He has probably come 8 o'clock in the morning for his round in the hospital. And now he is sitting in the OPD till 8:30 p.m. A consultant sitting in the OPD at 8:30 p.m. And he rang me up and he says, ma'am, my OPD did not finish till 8:30. I did not think it right to disturb you at that time. That's why I did not come. So this is the burden that the profession is carrying because the numbers we have are few and the population is out of control.
And I guess at AIIMS, it becomes that much more difficult because everybody wants to go there.
Yeah. Now, everyone wants to go there. I was asked to have a blood test done, which couldn't be done by sending my blood. I had to go to a particular lab where they could take the blood, immediately process
Sure.
it, right? So, and that lab was 3 buildings away. So I couldn't walk to that, so they got a wheelchair. And the guy who was pushing the wheelchair, all he was saying is, side ho jao, side ho jao, side ho jao. The corridors are flooded with people. To move a wheelchair through those corridors, you can only say side ho jao, side ho jao. So that is the burden AIIMS is carrying. AIIMS Delhi is carrying.
On a lighter note, I remember a couple of years back, there was somebody in our office that got injured, had to be taken to the hospital, and I took her to Safdarjung Hospital. I put her on one of those stretchers. She had a bad foot injury. I put her on the stretcher. It was 11 in the night. And I said, now you need to be a car horn. Just keep beeping while I push you in. And that's what she did. She had to keep beeping the entire way in because that's the only way she would get space for her to walk in. And we went into emergency, and at 11 in the night, it was full, and all the doctor did was looked at her foot, said,
Get an X-ray.
I'm not sure if this is a fracture. It doesn't look like a fracture. Go home, rest. If it's still paining in the morning, go get an X-ray done. But yeah,
So
that's...
that is the situation, you know that.
So, what sort of a role can, and that brings me to my next point, what sort of a role can technology play in this? And why not more of it?
Yeah. What is the cost of technology?
Anything from free to super expensive.
Yeah. So if you go directly for technology, it's just the healthcare budget does not permit that.
Sure.
So you can't. What we need to do is what is called public health care or preventive health care. The bulk of our problems would be solved with preventive health care and public health care. All the institutions in the North American continent, if they have a medical school, they also have a public health school in the same institution. So there is a filtration process. In the UK, there's the National Health Service. You have to go to your local GP. You cannot go to a specialist at the first time.
Right.
Only the local GP can refer you to the specialist. This system does not exist in India. What we need to do is adopt this preventive health care or the National Health Service pattern. The American healthcare system does not fit into that. It is very expensive and very delayed. You want to get delayed even in the UK. One of our professors, Lady Harding professor, she had a project which was on circulatory system. And she had retired as professor of medicine in Lady Harding. She was going to the UK for this conference. And there, while going to the meeting, she slipped, fell down. So they picked her up and went and deposited her at wherever she was staying. And they said, your X-ray will be done in 3 weeks. So she rang me up from London and said, what do I do? I said, you catch the next flight home and we will look after you. So she caught the next flight home. I sent the ambulance to the airport to bring her to the hospital. We did the X-ray and looked after her. If she had stayed in the UK, she would have to wait 3 weeks.
Right.
So that is the situation of healthcare, even in those countries who are supposed to be overdeveloped.
Right. And I guess right now, specifically in the US, and of course there are very conflicting views on that, they are working on revamping the entire healthcare system with Mr. RFK Jr. at the helm of it, talking about vaccines, talking about food habits, talking about the underlying causes of healthcare. I think they're currently working on on some kind of a project where they are saying in less than a year, actually in 6 months, they will come up with some report on the underlying cause that has caused an increase in autism and diabetes in the country.
Well, they probably will succeed in doing that, but we are nowhere near that yet.
Right.
So we cannot ape them. We, as I said, we have to address primary health care and public health care. That's where we can spend the little money that we have and save the specialists from seeing coughs and colds. Why should you see coughs and colds when you have been trained to do a specific job?
Right. So, in fact, that is where I was actually asking about the use of technology. I am not talking about, robotic surgeries. Yes, they are important, and wherever they can be affordably put in, they need to be. I was actually talking about the use of technology in primary healthcare.
Okay. Now, primary health care, use of technology comes in when you get records that can be maintained with the present technology available, so that you have a card which shows what your uh, health status has been from birth till the
Till
time
now.
you go to
Right.
the doctor. So technology can be used there. Secondly, since we cannot create as many medical colleges that are required and train people for healthcare at the doctor level, we can certainly train them at the nurse level and through telemedicine. Telemedicine is something that you can do and reach the remotest corner of the country. So technology can help totally. And then if I'm at AIIMS, I can connect with the remotest corner and teach the health worker there what to do for a particular thing.
Right.
I can train the health worker so that the patient does not have to travel even to the district level, leave alone to the center.
Right. And that's, I
That
guess,
technology should be used. There is no reason why we cannot use that technology. And if we can fight a war with Pakistan using all the technology that we have, surely we can use this
surely must be able to
technology in
use it.
healthcare.
Absolutely, and that's where I see a missing link right now. There are some places where technology is becoming acceptable, but I still see a lot of doctors not really being very comfortable with the use of technology in a lot of primary healthcare. I'm not talking about super specialization, but specifically limiting it to the primary
The
healthcare
primary
area.
healthcare, you can use it the way I've said. Keep records. You can transmit. A doctor sitting in AIIMS can connect with the village level worker and explain to him
Right.
what the patient is suffering from. And you can record, you can even record ECGs. They can record ECGs and transmit them.
Right.
So that the patient then, I mean, heart care is one of the misdiagnosed conditions. People get a pain in the tummy, it may be related to the heart, and they are treating the patient for tummy problems where it is really a cardiac problem. So technology can be used there and immediately transmitted to the center. Doctor can say whether the ECG is normal or not normal. That will totally change the uh, picture and the way you will treat a patient. So you can bring down death rate by using this type of technology.
Absolutely. In fact, one of the things that I always find very interesting is healthcare in India, in many cases, doesn't become a system of who needs it the most, but actually becomes a system of who has the best connect to be able to get to a specialist and get something.
Yeah, well, we, and you must have heard this, uh, health is wealth. Today, wealth
Wealth
is
is
health.
health. Absolutely. Absolutely. And I mean,
And accordingly,
I'm not even talking about the cost of healthcare, which
No.
in our country has, I guess, ballooned probably the most
Yeah.
if I look across the world right now.
Yes.
One other very interesting thing that I always saw. So I've spent nearly 10 years in the US. You would go to a doctor and there will be somebody who will take you. There are, there is this joke around, there are multiple levels of waiting rooms. You
Yeah.
move from waiting room 1 to waiting room 2 to the waiting room 3, and probably waiting room 4 is where the doctor would come. And in most of these waiting rooms, some nurse or somebody would come, they will take all your parameters, they will do everything. The doctor will simply come, look at a card, probably ask you one question, write down something, spend literally a minute to 2 minutes with you, and go away. In India, I guess most patients would be offended if that happens and will call the doctor not really functioning well if that happens. And I guess that also goes a long way in the kind of healthcare scenario that we see, wherein doctors end up spending, specifically with patients with means. They end up spending a lot more time. They end up kind of having to do a lot more primitive stuff that could even be done by nurses and all, which you already talked about, can be trained to other people. Let's get back to your book for a minute. Any specific insights from that? So, anybody reading it, what should they expect to get out of the book?
They should know what this current scenario of healthcare is, and what we lack and what we should look for in the future.
Okay.
Past, have no regrets about the past. Past is gone. You must prepare for the future.
And as I was telling you, when I first saw the book and read the book, being somebody who is very interested in politics, I actually got a little bit of political history and, in that. So for me, that part was also very interesting. Of course, the insights into healthcare are, of course, there, and that's what I would have expected. But that other piece also kind of was very interesting, at least for somebody like me.
Yeah.
Okay. Now, specifically in terms of India's healthcare system, what would be the top two things that you think need to be fixed?
No, I told you, primary health care.
Okay.
That is the only answer. Now, and in the West, the nurse has a particular status. In India, the nurse is at the bottom of the ladder, right? If we don't train her, then we are wasting our money, really. We need to have people at the lower level to be able to look after minor illnesses. That is what I firmly believe in. And if I was the health minister, I would certainly make sure that we create public health and preventive health care. And at the moment, only filtration system to get to the specialists. We have a number of specialists. We can look after.
One common aspect that I hear from medical health professionals is one, they are not able to devote as much time to keep themselves updated with what all is going on. So they are so busy treating the patients that they have that they sometimes miss out on what new technology innovation or what new practice or what new stuff is coming up.
Yeah.
And second, many of them also talk about the lack of mentorship that they are able to get through their career. Your thoughts on that?
Yeah. Well, Rajkumari Amrit Kaur, who set up AIIMS, when she became the first health minister in independent India, she said that she talked to the 17 medical colleges that existed at the time of partition. She talked to their chiefs and wanted to find out why they could not take in more, they couldn't train more people because many more were required. And the answers she got was that we don't have teachers. So if we don't have teachers, how can we take in more medical students? So Rajkumari then decided that if that was the need, we need more doctors, and the colleges that exist do not have teachers. She then thought that the institute that she was going to build would have a job, a trinity of responsibilities. Patient care would be the last. The first would be teaching. Second, if you're a teacher, you have to research to be able to update it and teach. And healthcare would be the last.
Sure.
This is what she envisaged. But this is not what happened. As you rightly mentioned, that a doctor has spending so much time on healthcare that he doesn't have enough time to become a teacher or a researcher. Very little time. She ensured that we put up that sort of a system, a trinity of jobs. And a trinity is really only in the medical profession. It's not in engineering or management that you do teaching as well as research as well as patient care. They only have teaching and research.
Teaching and research,
They
yeah.
do not have the patient care component. But the medical personnel has that component also. And it's so telling that when you go up for an interview, the first thing the board asks you, what is your research? Your promotion depends upon the research you have done. So you see the contradiction in the healthcare system. You have to do research and you have to do patient care. So it's telling hard on the doctors.
Right. In fact, I remember I was once in a lecture, I was talking to engineers. I come from an engineering background myself, and they were talking about how how proud it is to be an engineer. We solve all these world problems and everything, and we were just getting into this discussion about engineers versus medical professionals. And right now, engineering gets a huge role to play in medical profession in terms of technology and everything that they bring in. And we were just talking around that. And my first response to them was, I will hear you and agree with you the moment you give me something to fix a running motorbike, while it is running. A doctor needs to do that. Cure the patient while the patient is working. While the heart is running, you have to repair the heart. You don't usually repair engines like that. You usually stop them. You usually do something else, and then you repair the system. And I think that in a lot of ways, at least for me, looking at it from a system perspective, is probably the difference between a medical professional and an engineer.
Yeah, so you know that. So the doctors are really overburdened. It's all right clapping on thalis and saying, good, you are doing a good job as they did in COVID. But it's not really solving the problem.
I think the teachers and the doctors are two professions that had to almost give everything that they had during the pandemic. And the challenge that they kind of went through hasn't really recovered much from there. The number of people, and I mean, I can give my experience as an entrepreneur, the percentage of people that would fall sick on a week by week basis, I think is probably 3 to 4 times more in a post-pandemic. I'm not even talking during pandemic. In a post-pandemic world than what it used to be in a pre-pandemic world. And I can't even imagine the kind of pressure that it is putting on healthcare, because there are just so many more people. Of course, the healthcare system, while it has improved, temporarily and in some ways in a small percentage, but the amount of burden on healthcare has increased so significantly over the last few years.
Yeah, I don't think there's any doubt on that. And it's not going to be solved easily because this pandemic with COVID-19, now they're saying a new variant is coming. And back to your masks. It may be true. So the point is that we have to live with this. And preventive healthcare is part of it. Whether it really does what it's supposed to do in case vaccinations and COVID and all that is still to be proved. Because post-pandemic, we've had a high number of post-COVID complications.
In fact, as I mentioned to you earlier, I now work in the area of mental health. And my mental health, how I got into mental health is actually very unique. The day before the first lockdown happened, I was a digital marketing entrepreneur at the time. I used to run an agency. I was doing marketing for multiple different brands and healthcare organizations and governments and so many other verticals. I put a funny, in my view at that point of time, what was a funny Facebook post which said, "I hope Modi ji has kept enough money in the budget for suicide prevention and depression." And that post actually got a lot of people coming back and talking to me. Of course, COVID was a time when people had very little other than to talk to each other. So many people came and talked to me. I actually thought a lot about it, spent literally the next year and a half to 2 years looking at what was going on in the mental health industry. And I realized while I was half joking when I put that statement, but how true that was. And I guess we are all seeing the impact that it had on the entire humanity as a race
Yeah.
across the globe, not even in one specific country or one
Yeah.
specific gender or one specific region or one specific community across the globe. In fact, mental health in that sense is probably one of the greatest unifier, which puts everybody in the
Same category.
in the same category. In fact, some people might even say that mental health is a disease that doesn't really hit you when you're working on your survival, because you got bigger things to worry about.
Yeah, that's true.
So yeah, from a doctors and medical health professionals perspective, what's your point of view on mental health for the doctors and professionals, and what more can be done in that area?
You see, in India, we have so many superstitions. And those superstitions take you away from scientific healthcare. And scientific healthcare, it looks after mental health also. Whereas to get rid of the superstitions, which a high percentage of even educated Indians follow, it is very difficult to teach them that. So you have to, I think, start teaching children in school and the teachers teach the trainers first. The trainers have to be taught to be able to teach generation next. So you have to address the superstitions that exist in society in India on a large scale, north, south, east, west, everywhere.
Sure, sure. Fantastic. Thank you so much for these insights. As we get into the next part of this program, one thing that we do is what we call as a rapid fire round. So I will just ask you a bunch of questions, and your first thought that comes to you.
Okay.
Um, Biggest myth about medicine in India.
Biggest,
Biggest myth about medicine in India.
you are talking about modern medicine.
Modern medicine.
Not Ayurvedic medicine.
I'm not talking about alternative medicine.
Okay. So the biggest myth is that we have enough money, we'll give it to you. The government is saying. Whereas in practice, that's not true.
Okay, so the government
Healthcare is neglected.
healthcare is neglected in this country. Okay, one quality every doctor must have.
Every doctor must have a passionate attachment to his profession.
Okay.
And because the doctor is really what you take an oath, Hippocrates' oath, when you finish medical school, is really that you must provide healing to a patient, not really an MRI to a patient.
A life lesson that you got from the corridors of AIIMS.
Life lesson that I got, again, I would say that healthcare must start at the preventive level. I tried my best to start an emergency department, treating emergency as a specialist, because the feedback I was getting from patients, whether they were at the lower strata of society or at the highest strata of society, was that casualty or emergency was not running properly. And I tried to start off an emergency department and treat emergency as a specialty. But unfortunately, at that point in time, my faculty did not agree with me.
Sure.
They said, we have been created to be specialists and to be teachers. We cannot be running an emergency department.
And was that at AIIMS, or do you think that's
At AIIMS.
propagated across the
There was
institutions?
no, you see, the junior most person sits in casualty or in emergency. He or she calls the consultant when required, right? but he's not trained to be in emergency. When he is in his training years, no one teaches him emergency. Emergency really means you have to be on your toes. Whereas the other thing that is very badly neglected now is family medicine. So, in family medicine, you need to be calm. You need to listen to stories again and again of depression or whatever else the family has, really. But in emergency, you have to be on your toes. So, if you are not trained to be on your toes, you cannot run an emergency department.
Sure.
So, one feedback I got early in my directorship was a patient who was well off, brought to the emergency because he was having difficulty in breathing. And when he got into the emergency, the doctor started taking his history and asking him, "What is your income? What is your job?" He said, "You can write my income whatever you want to, 10 lakhs, 20 lakhs, but please give me oxygen." The doctor was busy writing. He was not thinking of his symptoms and giving him oxygen. So he grabbed the oxygen, put it to his thing. So the point is that people have to be trained for the job that they are given to do. And if they are not trained, then you are missing out on something.
So while we did not get to talk about radiology, but what is it, something that patients don't understand about radiology?
Why the patients don't understand about radiology is because the radiologist gives his or her report to the consultant. There is no direct link that the patient has with the radiologist. But the consultant knows the value of the radiologist, whereas the patient does not know because there is no follow-up that they would have with the radiologist. They will have a follow-up with the clinician. So they don't know the value of the radiologist.
On a side note, how do you get rid of that noise in the MRI machine?
How do you get rid of that noise? That noise, you have to train the consultants to appreciate your value.
Sure.
So many times, out of number, I would have made a diagnosis which the clinician could not have made without my help.
Sure.
So that's where we are.
Your personal mantra for tough days?
For
tough days?
Keep calm, don't get worked up. You have a job to do it.
Okay. And know that there is some light at the end of the tunnel.
And know that there's always room at the top.
Sure.
You can reach there.
Sure. Sure. Fantastic. It's been a true honor to be able to talk to you. Before we end this program, any last thought that you would want to leave our audience with?
The last thought, again, I'll take you back to primary health care.
Sure.
If you have to improve the health or the working manpower in this country, you have to address primary health care. Primary health care is the basis of the economy in this country. If you don't have healthy workforce, you cannot have a healthy country.
Sure. Thank you so much for that. On that note, I would just add one thing. So, taking cue from your conversation around primary healthcare, I am currently on the mission of making mental wellness available within the primary healthcare. I'm trying to create a system where a doctor is able to create and look at a patient, identify what sort of stressors the individual may have, and be able to progressively work through in that sense. And I'm not just talking about working with the psychiatrist and the psychologist and the mental health professionals, but even to the level of physicians or even to the level of healthcare organization being able to do that. And also make that available to doctors and nurses who face significant amount of stressors, as we talked about, the kind of changes that have happened in the industry, the kind of pressures and the kind of stresses that have been put on the system during COVID, and they are continuing even in the post-COVID world.
Yes, that is true.
So, Dr. Bhargava, it's been a true pleasure, a true honor to sit with you, to chat about your experiences, to talk about healthcare in India, and the availability and the need for increased healthcare capabilities across. Thank you so much for being on this program.
Yeah, thank you for having me on your program. And I leave you with this: use the technology that is required in the remotest corner of this country and improve the healthcare through technology. Thank you very much.
Thank you. And for everybody, do read the book, The Woman Who Ran AIIMS.